Okay, let's pick it back up again here. Start this. All right. Okay, so here we go. So let's now start talking about some of the major labs and lab tests that we run into regarding fluid and electrolyte balance. And I'm going to talk about, first of all, individual electrolytes. And we'll talk about the tests that look at those. All right, so first and foremost, I want to talk about one of the most important electrolytes, and that is sodium. So sodium. Now, sodium, to review from pharmacology, where is most of the sodium in the human body? Is it inside or outside of the cells?
Sodium outside.
Most of the sodium is extracellular. The majority of the sodium in the human body is extracellular. Right, it is the primary or the chief or the principal extracellular cation. So when we measure sodium, the normal level of sodium in plasma, in blood plasma, so we're looking at the intravascular compartment, is 135 to 145 milliequivalents per liter. That is the normal blood plasma concentration of sodium. You guys okay with that? All right. Then there is potassium. Now, is potassium primarily intra or extracellular? It is primarily intracellular. So, because it is primarily intracellular, would we expect its plasma concentration to be very high or low?
Low.
We expect it to be low, right? Because most potassium's in the cells. And are we actually measuring electrolyte concentrations in the cells? No, we're measuring it in the blood plasma. And so its value is going to be quite a bit lower, 3.5 to 5 milliequivalents per liter. Now, these ranges are going to vary slightly from textbook to textbook and even from laboratory to laboratory, right? So some sources may say 3.5 to 4.5 instead of 3.5 to 5, okay? So there's a little bit of wiggle room on these, but these are generally our normal ranges. All right, you okay with that? Okay. A rule of thumb that I want you to remember is wherever the sodium goes, so where sodium goes, what will follow?
Water.
Wherever sodium goes, water follows. All right, water follows sodium. All right. And the next rule of thumb is sodium imbalances. Imbalances of sodium primarily impact the brain. And they don't only impact the brain, but the most significant or the most substantial signs and symptoms that we're going to see in patients are going to be neurological. Okay, so sodium imbalances are very good at causing neurological dysfunction. Right? So sodium hits the brain. Now, potassium is a little different because it's inside of the cell. And potassium imbalances primarily impact the heart. All right, specifically the conduction, cardiac conduction. All right, so sodium imbalances tend to impact the brain, right? So neurons are very sensitive to swelling, right? Whereas other cells in your body can accommodate swelling or edema a little better than cells within your brain, because your brain is encased in a compartment that doesn't like to move a whole lot. Okay, you guys good with that? Okay. There are some other ones that we look at. Sodium and potassium are probably the two of the most critical and most common imbalances that we run into. Some others that we might run into, we might look at are chloride. Chloride. And the normal value of chloride is 96 to 106 milliequivalents per liter. 106 milliequivalents per liter. All right. Another one that we run into is phosphate. Phosphate is typically not measured in milliequivalents per liter. It's actually measured in milligrams per deciliter. And so phosphate, PO4 minus, its normal range is 2.3 to 4.7 milligrams per deciliter. Per deciliter.
What's that one?
Huh? Phosphate. Yes, phosphate. All right. Magnesium is another one. Mg plus 2. And it's normal, again, these are all plasma. These are in the blood plasma, right? 1.3 to 2.1 milliequivalents per liter. And then finally, I want to just mention calcium. Ca plus 2. Magnesium and calcium are in those group 2 metals, so they tend to lose 2 electrons. And I'm not going to give you a value because there are different values, and then there are different, there's what we call ionized and unionized calcium. And so I'm not going to give you a range at this point on calcium because there are different ways of looking at it and measuring it. Okay, so here are some of the major labs and some terminology that you're going to need to know. So, if the sodium is less than 135, that is a condition known as what? Hyponatremia. Hyponatremia. Good.
It's less, right? Less than one.
Right. Less low sodium. Natrium is an old school name for sodium, and that's why sodium has the atomic symbol of Na. Right? Natrium means sodium. You guys good with that? All right. Less than 135 is hyponatremia. Greater than 145 is hypernatremia. High sodium in the blood. Okay? Good with that? Potassium. Low potassium levels, less than 3.5. That is a condition known as Hypokalemia, right? Greater than 5 milliequivalents per liter is hyperkalemia. You guys okay with that? All right, good. Chloride. A chloride value of less than 96 is hypochloridemia. And greater than 106 is hyperchloridemia. You guys okay with that? Some people may even say you are hyperchloremic, right? Or hypochloremic, all right? Phosphate. A low phosphate is hypophosphatemia. Hypophosphatemia. And a high phosphate is hyperphosphatemia. Is okay with that? Magnesium. Low magnesium is hypomagnesemia. High magnesium is hypermagnesemia. Okay with that? And then finally calcium. A low calcium is hypocalcemia. You guys okay with that? And a high and elevated calcium is hypercalcemia. You guys okay with the terms there? Okay. So these are some of the major electrolyte imbalances that we're going to talk about. Let's talk about how we assess What kinds of labs are used? All right, so what we tend to do is we will draw a sample of blood from the vascular compartment, right? And then we will measure that blood using a test, and there are two major tests that are used. The first one is something known as a basic metabolic panel or profile. This is abbreviated as a BMP, a basic metabolic panel or a basic metabolic profile. This is sometimes referred to as a Chem 7 or an SMA 7. And so some people will also refer to this as a blood chemistry. Right, so when you guys are in clinicals next year, right, and you see this ordered, right, this test ordered, a BMP or Chem 7 or SMA 7 or a blood chemistry, a basic chemistry panel, this is what it's talking about. So as the name suggests, it looks at 7 different values, right? And those 7 values, this is called a fishbone that I'm doing here. This is just a shorthand way of documenting the basic metabolic panel. You won't often see this in the patient's chart unless the ER physician or the physician that you're working with writes it and puts it in. They may. You'll see the sodium, the potassium, right? You'll see the values. But this just helps me remember the 7 things that a basic metabolic panel looks at. First thing is the sodium. Okay, it looks at the sodium. It looks at the patient's potassium. Okay, it looks at the chloride. It looks at the carbon dioxide content and again, this is in the vein, right? And some people will even call this venous bicarbonate, and we'll explain why when we start talking about acid-base balance. Looks at something known as the blood urea nitrogen or the BUN. The blood urea nitrogen, the BUN, and the creatinine. And then finally the blood glucose. All right. So 1, 2, 3, 4, 5, 6, 7. Those are the 7 things that you look at on a basic metabolic panel. You guys okay with that? Now there is another kind of a blood chemistry known as a comprehensive metabolic panel, or a CMP. So a comprehensive metabolic panel, or a CMP, or some people may call this a Chem 12, because it looks at 12 things, right? So a CMP looks at the 7 things within a basic metabolic panel, so a BMP plus a few other things. And those things are the calcium, plus the calcium, the blood albumin, the bilirubin, the total. There are 2 types of bilirubin, conjugated and unconjugated. This tends to just look at the total bilirubin. The total protein, and then what are called the liver function tests, or the LFTs, right? So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. You see where that 12 comes from? But we hide a few things here. So when you look at the liver function tests, there are actually 3 individual tests that we look at. And these include the ALT, the ALP, and the AST. So that's what a comprehensive metabolic panel is a BMP plus calcium, albumin, total bilirubin, total protein, and the liver function tests. Does that make sense? So let's just talk about what some of these things look at. So we know the sodium, we know the potassium, we know the chloride, right? We'll talk about venous CO2 a little later on, so we'll just plant a little flag there and put it on the back burner. Do you guys remember what the blood urea nitrogen and the creatinine look at?
Kidney function.
Good. Yeah, kidney function. Right? I don't want you to memorize the normal values because they're easily referenced. It'll tell you right on the lab printout if they're high, low, normal, critically high. But what I want you to remember is the higher these, higher values indicate compromised renal function. All right? All right. The higher the BUN and creatinine, the more compromised kidney function. There are lots of things that can do that. Even just being dehydrated can cause the BUN and creatinine to go up. All right. And glucose, well, hopefully glucose is pretty self-explanatory.
Is there like, I think, isn't it like if the creatinine is elevated and the BUN is not, that indicates something specific or vice versa?
Yes. Yes. And we'll get there. I'm not really going to go into the nuance, but yeah, you're absolutely right. And not only that, but there's actually a ratio. There's something called the BUN to creatinine ratio that can help you differentiate. But yeah, the creatinine is really a big indicator of the actual function. So you could have a normal BUN and a really high creatinine, and be in trouble. But yeah, but we'll talk about these in some detail later on. But at this point, I just want you to remember that these are associated with kidney function. They tell us something about how the kidneys are functioning. The higher they get, the more dysfunction we would generally expect to see. Okay, the calcium, well, that's pretty obvious. We're looking at the calcium in the blood. What's albumin again? Remind me what albumin is.
Protein.
Albumin is a specific kind of protein in the blood. In fact, albumin is the most common protein that we have in our blood, right? And if your albumin levels are very low, you have what's known as hypoalbuminemia.
For cirrhosis, right?
Right, and that can happen in cirrhosis. That's one situation, right? Because that's where you make albumin, your liver. And albumin is very important because it's a large molecule. It's a large solute molecule in your blood, and it exerts a lot of oncotic pressure. Do you guys remember that? Oncotic pressure. That's pressure that holds water in the vascular compartment due to osmosis. And hydrostatic pressure is pressure that tends to push water out. And so somebody who has very low albumin levels, water tends to leak out of their blood vessels, or can, right? And that is one of the reasons that we can see lots of fluid shifting in people with renal failure. Or not renal failure, but hepatic failure, liver failure, due to the loss of oncotic pressure and the backup, and the increase in hydrostatic pressure due to a backup of circulation in the portal system. Bilirubin. You guys remember where bilirubin comes from?
The breakdown of red blood cells.
Red blood cells, yeah. Bilirubin is a byproduct of red blood cells. And remember, red blood cells have a fairly short half-life. Red blood cells don't have mitochondria, they don't have a nucleus, so they can't make proteins, and so they're basically just bags of hemoglobin.
Bilirubin is the byproduct?
Yeah, so when red blood cells break down, one of the major waste products that's produced is bilirubin, right?
It's like getting a bruise, right?
Hmm?
It's like
Yeah, when you get a
white
bruise. Yeah, and it turns yellow as that blood is kind of being reabsorbed. That yellow is due to bilirubin in that blood, that hematoma. Yeah, so as your red blood cells break down, if your liver's functioning normally, those red blood cells, those products will go to your liver, and your liver will conjugate that bilirubin and attach. It'll be metabolized essentially, and large molecules will be attached to the bilirubin, and then that bilirubin will be put into bile, and that's how we get rid of bilirubin. That's why bile kind of has that bilious, that yellowish dark color, because it has all that bilirubin in it. And so very high levels of bilirubin suggest that your liver may have a problem, right? Lots of things can cause this, right? If you have like lots of trauma or you have a lot of breakdown of red blood cells, it may not be the liver, it may be some other process causing breakdown of red blood cells, like babies, right? Babies that have lots of hemolysis or lots of breakdown of blood can get what? What can they develop? Jaundice due to the increase in bilirubin. And that's not necessarily that their liver is failing. It may just simply be that they have more hemolysis or breakdown of red blood cells than their livers can handle. Total protein, that's just the total amount of all the different proteins in the body. And then what do you suppose the liver function tests look at? The liver function, how about that, right? So the bilirubin and the LFTs tell us something about the liver, right? And again, we can go into a little more detail on the specific tests a little later on, but at this point I just want you to know, generally speaking, the higher your LFTs and the higher your bilirubin, the more compromised your liver function may in fact be.
And what did you say again? Albumin is the main.
Albumin is the most important protein in your blood. Yeah. There are many other kinds of proteins, right? Even antibodies, right? Immunoglobulins.
With increased albumin, it also might indicate liver
Decreased albumin.
decrease.
Yeah. Decreased albumin. Yeah, that's hypoalbuminemia. Yes. Okay. You guys good with that? So far, so good? All right. So what I want to do now is, if you look in your book, you will see the first electrolyte imbalance that gets talked about is sodium. And I see a total of 2 paragraphs and a little table. And that's the only discussion there is about sodium. You guys see that there? I believe it's 422 in your current edition. I assume you guys probably know that because you all read. Yeah, of course you did. Mm-hmm. Yeah. Yeah. I believe it's 422, is that right? You're about? Yeah, in the current edition. All right. Sodium is far more important and far more nuanced than just 2 paragraphs. So we're going to spend probably an entire lecture just talking about sodium. So what I'm going to do is I'm going to plant a flag there, and we're going to move on, because sodium is super important, and if we don't get it right, you can destroy a person. If we mismanage sodium, we can destroy a person. To make it even worse, it's going to be really hard for us, because what is our typical operating environment? Yeah, our typical operating environment is outside of the hospital, right? So it is inherently going to be difficult for us. So a lot of the stuff I'm going to talk about with sodium isn't going to directly apply if we're not in an environment where we can get labs and we have a really good history and physical. But I still want to cover this material, because if sodium imbalances are mismanaged, it can be absolutely devastating for the patient. This is a really hard thing to manage. Okay, so we'll plant a flag and we'll come back to that later. So what I want to do is I want to talk about potassium imbalances first, right? I'm going to talk about potassium and I'm going to talk about calcium imbalances. All right? And we're going to talk about those first. Now, you guys should kind of be up on potassium. We talked about it in a little bit of detail during pharmacology. And honestly, I almost wonder if this would be a better class to take before pharmacology even. For whatever reason, I don't know why this is the last of the prerequisites I've taught, but I've always wondered, wouldn't it be cool if we did this first, and maybe this would help with pharmacology? I don't know, but
Thank you.
yeah, it might, because at least now you have a real good foundation to work from. But be that as it may, let's talk about potassium imbalances. So you've got hypo and hyperkalemia. And what I want to do is I want to talk about hyperkalemia first. Because it can have it can truly have some life-threatening implications, and there are some things that we can do to actually identify this outside of the hospital. This is one of those electrolyte imbalances where we can at least have a really strong suspicion that this may be what's going on. All right. So hyperkalemia is a potassium level in the plasma greater than 5 milliequivalents per liter. So what do we say about potassium imbalance in general? Potassium imbalance in general is going to impact what? Tends to impact the heart, right? So there are 3 major ways that we can develop hyperkalemia, all right, high potassium level. The first way is a decrease in our ability to eliminate potassium, right? So if I cannot eliminate it from the body, it's going to build up. So decreased elimination. And what do you suppose the primary way of causing decreased elimination of potassium? What is the primary way of? Renal failure, absolutely, right? The kidneys shut down, they can't eliminate anymore. This is a constant concern in somebody with possible renal failure or with a history of renal failure, all right? There are some medications, though. We talked about this in pharmacology. Spironolactone, right? Spironolactone, what is that? You guys remember that? Spironolactone, or Outolact, is a potassium-sparing diuretic, right? So if somebody is on, say, spironolactone, they're going to have a higher risk for hyperkalemia because instead of peeing their potassium off, they're holding on the potassium, right? Normally, the run-of-the-mill diuretics that you guys run into, the loop diuretics, for example, like furosemide, they tend to cause you to lose potassium, right? They tend to be what we call non-potassium sparing. But potassium-sparing diuretics cause your body to hold on to potassium. So that's another way that you can have decrease in elimination. So your kidneys can fail. Certain medications like spironolactone, ACE inhibitors. ACE inhibitors can do this as well. And NSAIDs. Remember we talked about this in pharmacology, that the non-steroidal anti-inflammatory drugs can be very tough on the kidneys, right? So a history of substantial NSAID use can set somebody up for hyperkalemia as well. Does that make sense? Okay, so that's the first one. The second one is, the second major cause is potassium shifts. So potassium shifts out of the cell. Right? So processes that cause large amounts of potassium, because where is most of potassium in the body again? Intracellular. So some process that causes large amounts of potassium to shift out of your cells, right? Where would we see this? Well, massive burns. If I burn a lot of cells, the cell membrane is going to be compromised and potassium is going to have a tendency to do what? Leak out of those cells, right? So massive burns, crush injuries, large crush injuries, right? Someone gets crushed in a vehicle and they have lots of muscle and skin damage, right? Metabolic acidosis. And it's not going to be obvious right now why that is, but it will be when we get into acid base, right? What can happen is the more and more acidotic you become, you have a tendency for potassium to shift out of your cells, right? Acidosis drives potassium out of the cells. That's kind of the paradigm you want to think of, right? So acidosis drives potassium out of the cells, all right? And alkalosis would drive potassium into the cells. That kind of makes sense there. All right. And then the third way is just by taking too much potassium, just excessive intake. Right? I go to town, you have somebody on Lasix and they put them on potassium supplement because, right, they have a tendency to lose potassium, and then that person overdoses inadvertently or intentionally on potassium, or you're taking care of somebody in the hospital and they've been mismanaged, right? Because we know we can give potassium parenterally as well, right? You can give it as an IV infusion. You can even give large doses of potassium, and remember we talked about K-riders or K-runs, right? Maybe that patient was mismanaged and received too much potassium. All right, so these are the three ways: decrease in elimination, potassium shifts, and increased intake. All right. So what we are most concerned about is life-threatening hyperkalemia, right? So first of all, history in physical exam, right? You have to have some history that suggests a condition that can cause hyperkalemia. Well, that's the first one. And are there any other findings that suggest life-threatening hyperkalemia? In addition to history and physical exam. One of the major findings is going to be on the ECG, and I know you guys have not had ECG interpretation.
Being a rhythm?
Yes. ECG findings. This doesn't happen in every patient, but it happens in a lot of patients. And the classic findings that I want you guys to remember is hyperkalemia causes tall, peaked T waves. All right? And the more hyperkalemic you get, the taller and more peaked the T waves become. You guys remember what a PQRS key complex looks like, right? You got a P, a QRS, and a T wave, right? Looks something like that. So what happens in hyperkalemia is the T waves get tall and the P waves become depressed. Right, so the P waves will actually flatten out, and then the T waves become tall and peaked and kind of look like like a teepee or a tent. You see that there? Right, that's kind of a classic finding. Is a flattened out depressed P wave and a tall tented T wave. All right? And eventually what can happen is when you become super hyperkalemic, the P waves will go away completely and the T wave will kind of blend in to the QRS complex, and you get this really wide, bizarre pattern. And these patients are going to be at risk for cardiac arrest, right? They're going to be at risk for cardiac arrest, very high risk for cardiac arrest. So remind me, what is the treatment for life-threatening hyperkalemia? Because this is something we could potentially identify.
Calcium.
Huh?
Calcium.
Good. So step one, right? Step one, stabilize the cell membrane, right? Buy you some time, and we do that with calcium. Calcium gluconate, calcium chloride, doesn't really matter what your specific protocols call for, even though gluconate and chloride are given a little differently. At least how quickly we give it and dosing is a little different, but more or less the same. All right, that's step one, and then what's step two? So you bought yourself a little bit of time with calcium. Step two, you're gonna shift potassium into the cells, right? So you're gonna shift potassium. And how are we going to do that? We're going to do that with sodium bicarbonate, right? We're going to give sodium bicarbonate because that's going to make the vascular environment more alkaline, and that alkalosis is going to drive potassium into the cells. That's one way of doing it. We're going to give high doses of what? It's a very common drug that we carry. If we give high doses of this, and this is actually a side effect, albuterol, right? Hypokalemia is a side effect of excessive albuterol use. So we're going to go high dose albuterol. Right? High dose albuterol. And if we're in a situation where we're a setting where we can do this, we can give insulin and dextrose, right? Because insulin tends to drive potassium into cells as well. And then what's step 3 is not something we typically can do outside of the hospital. But what is it? So stabilize the cells, shift potassium into the cells, and then eliminate the potassium. Good. And what is the single most effective way of eliminating potassium in the setting of a life-threatening hyperkalemic emergency?
Potassium-sparing diuretics.
That's going to increase potassium. Huh? You might think if I give a non-sparing diuretic, yes, but that's going to take a while, right?
Just fluids, urination?
No. Dialysis, right? Dialysis. Dialyze them, right? Yeah. So calcium, to buy you some time, right? Bicarb, albuterol, insulin, dextrose to shift, to hide potassium in the cells, and then get them to a place where they can do emergent dialysis. Dialysis is also referred to as renal replacement therapy, or RRT, right? So if you see that in context to a renal patient, it means the same thing as dialysis.
On the ECG interpretation, would the peaked T waves and depressed P waves, would that be in all areas of the heart, or would it be in a certain?
It tends to be pretty global, yeah. And again, I'm not going to talk about it in any more detail than this, because we're going to have a whole ECG interpretation class, and we're actually going to look at examples of this, of hyperkalemia on the ECG. But it tends to be very universal. Yeah, it's not isolated any specific lead. Unfortunately, in something like, I believe something like 50% of patients that have hyperkalemia, they don't have any ECG changes. So it's not, you can't completely rely on it. It's not completely reliable, but certainly if you see it and you have some history, that really is really, really strong suggestion that's what we're dealing with there, right? Or if you're running a code on somebody and any of this history is going on, right, and you are not getting ROSC, one of the things you want to think about is, could this cardiac arrest be due to life-threatening hyperkalemia, right? And when you guys take ACLS, we'll talk about ruling out the H's and T's of cardiac arrest. You guys go with that? So that's hyperkalemia. Hypokalemia is low potassium, and there are 4 major ways that we can get there, okay? The first way is just simply not getting enough potassium in your diet, right? Somebody's not eating, maybe they're in a starved state, or they have really poor diet. Maybe this is somebody who is homeless, and they're just not able to get enough potassium in their diet, okay? The next one is just a excessive shift of potassium into the cells. So somebody who's taking too much albuterol, maybe they have a history of asthma and they're just pounding the albuterol, and they've put themselves into a hypokalemic state due to that. Epinephrine, right? If somebody gets a large doses of epinephrine, those kinds of things. Anything that can stimulate lots of beta receptors, so your sympathomimetics, could potentially cause hypokalemia. You can also lose too much, right, in the kidneys, right, renal loss. So you put somebody on a loop diuretic, for example, they can pee off their potassium, all right. And then you can lose it through your gastrointestinal tract as well. And these are what are known as extrarenal losses, right? So if someone has excessive vomiting or excessive diarrhea, they can lose potassium through vomiting and diarrhea as well. Does that make sense? All right. And it's not. I didn't explicitly say it, but I just do want to mention that in the the second point when I talked about potassium shifts. If you make somebody alkalotic, you can shift potassium back into cells, right? So if I give somebody a lot of bicarbonate, or I put them in a metabolic alkalosis, I can potentially precipitate hypokalemia as well, right? Now, hypokalemia presents a little different than hyperkalemia. Hypokalemia, the signs and symptoms are a little harder in some sense to determine, but oftentimes like general fatigue and muscle weakness and muscle cramps are the kinds of findings that you're going to see with hypokalemia. In severe cases, you can have real severe muscle cramps, and you can have some ECG findings as well. So in hypokalemia, instead of hyperkalemia, you may see that the P waves become tall and peaked, and then the T waves actually become depressed. So it is just the opposite of hyperkalemia, right? Hyperkalemia, the P waves get flattened out and the T waves get tall and tinted, whereas in hypokalemia, the P waves become more prominent and the T waves get depressed. Again, you're not going to see this in all cases of hypokalemia, but certainly if there's history that suggests hypokalemia, you marry that to ECG findings. So how would we treat hypokalemia? Huh? Give them potassium. Yeah, that's generally how we do it. Yeah, give them potassium. If it's really mild hypokalemia, right, maybe they just had little cramps, just feel a little weak, and say their potassium is 3.2, right? Well, that's pretty mild. Would we want to treat it aggressively? No, we just put them on oral supplementation, monitor them. If it's super low and their signs and symptoms are really bad, we may need to do what? We may need to actually give them potassium in the IV, or even do a K-run or a K-rider. And in general, electrolyte imbalances, in general, the more rapid the imbalance occurs, the more severe the signs and symptoms. Okay? So it's not just based solely on the lab values. You guys okay with that? It's not solely based on the lab value. It is also based on how rapid the electrolyte imbalance occurred. Right? So you could look at patient A that has let's say patient A has a potassium of 1.8. And if it took them 3 weeks to get there, their signs and symptoms may be pretty mild, whereas patient B's potassium went from 4.2 to 1.8 in 2 hours. Well, their signs and symptoms are going to be much more severe. Does that make sense? And the general rule of thumb is we only correct electrolyte imbalances as quickly as we absolutely need to, right? We only correct electrolyte imbalances as quickly as we absolutely need to, right? When in doubt, be cautious about correcting these, right? The only exception is, or one of the only exceptions is life-threatening hyperkalemia. If your patient has life-threatening hyperkalemia, you need to rapidly act, right? You need to rapidly get the calcium on board. You need to rapidly shift. But some of these other electrolyte imbalances, particularly sodium, slow and steady is going to be the order of the day. Does that make sense? Okay. So that's potassium. Let's talk about calcium next. Okay. So let me ask you a question. Is most of the calcium in the blood, first of all? No. You have very little calcium in your blood. Most of the calcium in your body is actually stored within your bones, right? Most of the phosphorus as well. All right, so that's one thing to remember, that most of the calcium in your body is actually in your bones. So blood values of calcium are, blood values can be a little tricky, all right? So let's talk about some of the major problems. The first problem that I want to talk about is hypocalcemia, okay? Hypocalcemia. Hypocalcemia is an abnormally low level of calcium in the blood. And what are some of the things that can cause this? Well, there are 4 major things that cause it. First major thing is simply decreased intake, right? You're not getting enough calcium in your diet, all right? Maybe you are not getting, because remember, you need vitamin D to actually absorb calcium, right? So if you don't have adequate amounts of vitamin D, you may not be able to absorb that calcium. You may have what's known as a malabsorption syndrome, right? Where do we see malabsorption syndromes? Well, we can see these in patients that have had surgeries to their gastrointestinal tract, right? For example, if you've had gastric bypass surgery. People who have had gastric bypass surgery are at risk, or at higher risk for electrolyte imbalances in general, because they can't absorb things as well, right? If they have lost a significant portion of their gastrointestinal tract, maybe they've had cancer, they had an injury, right, and they've had to take out a large portion of their intestines, right? This is something called short bowel syndrome. They're going to be at higher risk for this, right? So that's one way, is just you're not absorbing it, right? You're not getting enough of it in your diet, okay? There are conditions that can increase the amount of calcium that you lose out of your body. One of the most common is going to be chronic alcoholism. Chronic alcoholism, right? Certain diuretics as well can make you pee off more calcium. Endocrine disorders, all right? Endocrine disorders. Particularly disorders involving the parathyroid glands, right? Specifically disorders that involve suppression or sometimes removal of the parathyroid glands, sometimes inadvertently. We'll talk about that in more detail in endocrinology. And sepsis. Patients who are septic and in septic shock are at higher risk for hypocalcemia, all right? Hypocalcemia tends to cause neuromuscular irritability. All right? And there are 2 findings that I want you to associate with hypocalcemia. All right? I do not think that these are mentioned in the textbook, at least in the pathophysiology chapter, but I need you to put these in your notes because these are important. And they're easy to assess for. And if they have these suggest that this is somebody who is very sick with hypocalcemia. These include the Chvostek sign and the Trousseau sign. All right?
Can you write that down?
Chvostek. Ostek. Chvostek and Trousseau. T-R, I believe. Let me just make sure I get the spelling correct here. Trousseau. Chvostek's and Trousseau's. Chvostek's and Trousseau signs. So these are kind of the classic signs that we can see in somebody with life-threatening hypocalcemia. All right, so what can happen is Chvostek, I think of Chvostek cheek, right? So what can happen is if you tap the cheek and you stimulate the masseter muscle, remember hypocalcemia is very good at causing neuromuscular irritability. What will happen is the masseter muscle can start spasming. And so they'll have spasms of their masseter muscle when you tap the cheek. That is a positive Chvostek sign. The Trousseau sign is when you put a blood pressure cuff on somebody's arm and you pump that blood pressure cuff up, that person will have carpal spasms. All right? That makes sense? So you pump that blood pressure cuff up and they start having carpal spasms, tap the cheek and they start having masseter muscle spasms. Those two findings suggest life-threatening hypocalcemia. They can suggest other things too, right? For example, someone who's pregnant and has preeclampsia or eclampsia, they can have neuromuscular irritability that looks very similar to life-threatening hypocalcemia. So again, it comes down to history, physical exam, plus labs, right, to really kind of nail this diagnosis. Don't overlook getting a good history on your patient, right? So history is going to lead you to suspect one thing over another, right? You got a septic patient with pancreatitis that has a history of chronic alcohol ingestion with a positive Shavastic and Trousseau sign. That suggests hypocalcemia versus a 28-year-old female patient who is in the third trimester that has hypertension, protein in her blood, and neuromuscular irritability. Well, that suggests what? Preeclampsia. Does that kind of make sense there? Okay, so that's hypocalcemia. How do you think we treat hypocalcemia? Calcium. How about that, right? Give them calcium. All right. Hypercalcemia. Hypercalcemia is obviously what it sounds like is an increase in elevation in calcium levels, and there are four major causes of hypercalcemia. The first one is just too much in your diet, right? One of the most common ways that somebody can become excessively hypercalcemic due to diet is antacids, right? Not eating too much yogurt or milk or cheese, right? You have to eat a boatload, probably more than is consistent with life to really get there. But it's a much easier if you have somebody that is overdosing on antacids. They can get hypercalcemic fairly easily. What is a very common antacid? Calcium carbonate, Tums, right? Absolutely. So that's one way to get there. The next way to get there is just having various endocrine disorders. Parathyroid disorders, right, can cause this. Adrenal insufficiency, this is also known as Addison's disease, and we'll talk about that in a lot more detail later on. Certain cancers, particularly bone cancers like multiple myeloma, right? And that makes sense. If you have multiple myeloma, you have a bone cancer, that bone is breaking down and it's releasing all that stored calcium out into the blood. Does that make sense? Right? And then just a few other odds and ends like diuretics, again, can cause it. There is also a condition known as sarcoidosis. Have you guys ever heard of that? Sarcoidosis? And essentially sarcoidosis is a condition where you have abnormal proteins that can develop, and they can develop these plaques, these sarcoid plaques, and it can compromise organs. It's somewhat similar to another condition called amyloidosis, where you can get amyloid plaques that can develop, but we don't need to go into any more detail than that here. Okay, you guys good there with that? Okay. There are some other odds and ends, and I don't want to keep lecturing on this because I know we're coming up on lunch. I want to get you guys out here on break. But if you look in your textbook, I believe pages 424 and 425, there are some blurbs about phosphate and magnesium. Okay, I want you to make sure you just kind of read through those. Magnesium is a tricky one in that the signs and symptoms of magnesium imbalance, is it due to the actual magnesium or is it due to the underlying illness that's causing, it's really hard. So I want to spend as much time talking about hyper and hypomagnesemia, although hypermagnesemia tends to do what? Particularly if we cause it acutely. Good. It tends to suppress deep tendon reflexes. It tends to make your patient breathe slower and shallower, and it can decrease their blood pressure, right? So hypomagnesemia, acute hypomagnesemia, in the medical setting is something that we can cause, right? If we're too aggressive about giving people magnesium, i.e. you have somebody on a magnesium drip and you inadvertently overdose them, right? And remember, we talked about this earlier. If you have somebody on a magnesium infusion, you need to assess their respiratory rate and depth. You need to assess their deep tendon reflexes, right? Make sure that you're not overdosing them on magnesium. And then phosphate. Phosphate has a very close relationship with calcium, right? And they are often, the relationship is often inverse, and that is to say high phosphate levels tend to drive down calcium, and low phosphate levels tend to drive up calcium. So there is there is an inverse relationship that can develop with phosphorus and calcium, because a lot of the phosphorus is stored within the hydroxyapatite of your bones. But I think we've covered the main ones. So we've covered the potassium, hyper and hypokalemia. We've talked about hyper and hypocalcemia, hypermagnesemia, and I've talked a little bit about phosphate. I think I'm going to put you guys on lunch. After lunch, we will dig our heels into sodium and talk about hypo and hypernatremia. And this is a tricky discussion to have. So I think I will push that to lunch. One more thing that I want to mention. Just kind of put this in your notes. Albumin has an impact on calcium. All right? Albumin has an impact on calcium. So very high and very low albumins can cause falsely elevated and falsely lowered calcium levels. All right? We'll talk about that in a little more detail later on in the course, but I just want you to remember that, right? So if you see a panic, right, you look at somebody's calcium and it is panic level, right? It is panic high or panic low. Look at the albumin and determine, is the albumin normal or abnormal, right? Because it may be due to the albumin, and there is what we call a corrected calcium. There's a calcium correction that can be done based on the albumin level. So that's all I want you to know at this point. So good with that there? So far so good? Okay. So the hard stuff we'll tackle after lunch, and that's sodium. Sodium can be kind of difficult. Any questions? Or did that more or less make sense? Gone over. And what I talked about is more or less what's in your textbook.